This is a presentation of the evaluation of cannabinoids in stimulating the appetite of cancer cachexia patients. This presentation was created by Laurence Elliott, RN, BSN. The following two individuals were considered among my committee members: the DNP chair or Doctorate of Nursing Practice chair, and second reader of my scholarly project was Dr. Maria Snell, DNP, MSN, FNNP, FAANP. Another community member was Kayla Jansen, RN, BSN. One of the major side effects of cancer and cancer-related medications such as chemotherapy or biologics is cancer cachexia. Cancer cachexia is an illness that is characterized by the loss of skeletal muscle and is exacerbated by a cancer patient's lack of appetite. This lack of appetite and the cancer cachexia itself cause a multitude of issues with patient treatment. Patient treatment can be affected by a delay, multiple detrimental nutritional deficits caused by the wasting symptoms and lack of appetite and food intake, and can eventually lead to death, thus making the trigger for this project. A current medical treatment that is used to help alleviate cancer cachexia through increasing appetite is megestrol acetate. This, along with other traditional therapies, might be detrimental to patients as megestrol acetate can cause thrombotic events and death. A proven effective alternative to this medication is the use of cannabinoids to increase appetite, and cannabinoids have been shown to lower the risk associated with getting cancer cachexia. This begs the population intervention comparison outcome and time question of, in the adult patients experiencing cachexia from cancer, does the evaluation of a clinical practice guideline or CPG using the agreed-to tool as compared to current practice provide consensus among stakeholders to support the implementation of the CPG into practice? As a registered nurse at a cancer care clinic in St. Louis, I was witness to an abundance of patients that had cancer cachexia, or also known as muscle wasting. Cancer cachexia can devastate a patient's life and greatly interfere with their treatment regimen. These patients had a multitude of treatments along with their main chemotherapy to treat their wasting symptoms. These treatments and the cachexia itself caused patients to have adverse reactions, such as getting deep vein thrombosis, thromboemboli, or adrenal insufficiency and edema caused by one such treatment, such as megestrol acetate. Cancer cachexia can also lead to increased toxicity from chemotherapy, as most therapies are based on body surface area calculations. Thus, if a patient that is underweight has the dosage that they had at the beginning weight, they can go into toxicity. Patients also experience decreased quality of life and increased mortality rates due to their cachexia. With this in mind, the aim of the study was to create and evaluate a created clinical practice guideline favoring the use of cannabinoids over current traditional therapies. Upon reviewing and selecting current evidence-based articles to complete my scholarly project, there were three main themes found among those articles. To begin, traditional therapies were researched to compare to cannabinoids in many studies. Traditional therapies were found to focus on dietary changes through the use of a dietitian to increase caloric intake and replenish lost nutrition. Traditional therapies also focused on supplementation of nutrition through intravenous fluids and the use of pharmaceuticals such as glucocorticoids, non-steroidal anti-inflammatories, and progestogens. The next theme focused on cannabinoid effect on appetite, which showed that they did increase caloric reuptake and increased patient appetite. Also, the next theme was cannabinoid side effects and their interactions with treatments. Cannabinoids were found to have positive interactions with treatments when used in patients with cancers such as human glioblastoma. but negative effects in patients with female adult mammary carcinoma. Cannabinoids have also been found to cause cognitive impairments when using them. Along with this, literature has shown that cannabinoids can decrease pain, nausea, and increase mood in cancer patients. Along with the collected themes, there were some strengths and weaknesses that were found in the literature, such as the strength and the rigor of the scholarly article's collection and presentation of data, while also being non-biased in the presentation of any positive or negative data collected. But there were some weaknesses, such as the limited length of the study or the low cohort numbers. This scholarly project was framed based on Barbara Dossie's theory of integral nursing. This project was created to increase patient appetite and heal the patient as a whole individual, such as Dossie's theory proposes. Dossie's main concepts of healing an individual is based on healing the individual's ability, knowledge, and attitude, and can simply be put as the healing of the entire individual. The idea of using cannabinoids to increase a patient's appetite in cancer care to complement primary cancer treatments and goals is to ensure quality patient health care and is based on the idea of healing the whole individual while having nursing voices in healthcare. This project is essential to guaranteeing that an individual has an appetite to eat, to increase caloric intake, and gain weight, giving that individual the strength to take care of their basic human needs. Essentially, the theory makes up the structure for this project by using the uniquely complex patient realities, the idea and knowledge of nursing, and aiming to heal the individual as a whole. This scholarly project was a mixed method scholarly project that incorporated the collection and evaluation of both numerical and written data. Mixed method studies use quantitative and qualitative research to form a deeper understanding of the answer to the hypothesis being posed in a study. However, it should be noted that mixed method research is not just the use of two different paradigms, such as numerical and written data, but the creation of a third holistic paradigm for researchers to use in a single testable question. This holistic paradigm is seen in the scholarly project with the use of the agree-to tool's numerical values, each question being valued between 0 and 7 for each individual domain, there being 6 domains. This evaluated the overall effectiveness of the individual sections of the clinical practice guideline. Collection of these numerical rankings underpin the quantitative paradigm that there is a numerical answer for real-world studies. Along with numerical data, the scholarly project used the agree-to tool to collect comments from the stakeholders or evaluators and have them comment the improvements needed on the practice guideline to be accepted to practice, and also gave the overall acceptance of the guideline itself. As this scholarly project was an evaluation of a clinical practice guideline, the population studied was the guideline itself. The created guideline had 3 key statements. Key statement 1 was oncology providers should diagnose cancer-related cachexia in oncology patients that are experiencing anorexia followed by wasting symptoms, for example, loss of skeletal muscle and adipose tissue, to avoid loss of patient quality of life. Key statement number 2 was as follows. Providers should refer cancer-related cachexia patients for dietary counseling to prevent or correct the status of cachexia through dietary changes, oral vitamin replacement, or nutritional replacement. Key statement 3 was providers should recommend the use of cannabinoids in the treatment of cancer-related cachexia to increase patient appetite and caloric reuptake. Data collected throughout this project focused on the quantitative and qualitative data that was achieved using the agree-to tool. Qualitatively, the domains received comments that would suggest improvements or areas of excellence in the clinical practice guideline. Quantitatively, the project would be scored based on each individual question in the domain with a score of 0 to 7, and from these scores a percentage would be placed on the domain to show areas of weakness or strength of their guideline. This guideline could be scored with a variability ranging from 0 to 100% in each of the 6 domains, which culminated in the overall acceptance or rejection of the proposed guideline, with the expected primary outcome being the acceptance of the guideline. This percentage was calculated through taking the actual score of domains subtracted by the minimum score of the domain divided by the maximum score of the domain subtracted by the minimum score, and then multiplying it by 100. The collected data from the Agree-To tool was found to be strongest in Domain 4, the clarity of presentation, and Domain 6, editorial independence, with both scoring a 100%. The weakest point of the data was identified in Domain 5, with its applicability at a 75%. However, the scoring was still a good indicator of a strong clinical practice guideline. Along with this, Domain 1, scope and purpose, was scored at 96%. Domain 2, stakeholder involvement, was at 81%. And Domain 3, rigor of development, was also at 81%. These scores showed a relatively positive reception to the clinical practice guideline, thus showing that the guideline itself was deemed a strong contender for implementation into practice. Qualitatively, stakeholders wrote in that the guideline itself needed little to no work before implementation. Other comments included the guideline having quality in its creation but needing better techniques to audit the guideline. The overall acceptance of the clinical practice guideline was scored high, 5 to 6 out of a 7, and the guideline was recommended to be implemented into practice by all 3 stakeholders that evaluated the guideline. There were many facilitators and barriers throughout the data collection process that might have limited or assisted in results. The main facilitators found in the data collection process were the minimal funding needs, relative ease of correspondence with providers and stakeholders, and supportive committee members. Funding for the creation and evaluation of the project was low due to free access to the Agree-To tool, limited transportation requirements, and free communication tools to communicate with stakeholders. Ease of correspondence was due to all stakeholders having and able to utilize a secure email service to correspond with the main researcher. Also, the support and help from various committee members throughout data collection and analysis of said data made the process much easier. Barriers to the data collection process included provider stigma towards the use of cannabinoids in cancer treatment, time constraints, and communication breakdown. Each stakeholder had a relative bias towards cannabinoids, be it for or against, that caused some degree of resistance to grading the guideline. Each bias was addressed individually as to not skew data for or against the guidance itself. Along with this, time constraints to collect data caused some stress in completing the data collection process. The Agree-To tool takes time to properly produce quality results, so amount of time in the use of the tool to evaluate the guideline caused a barrier to data collection. Finally, ease of communication through the use of emails was a boon. However, personal schedules of individual stakeholders caused a breakdown of communication, causing a barrier to data collection. Some limitations found through the use of the Agree-To tool and its results showed the guideline itself, where the guideline's ability to be audited not being clearly described, there only being a single researcher for this project, no clear procedure for updating the guideline, thus hindering its ability to be implemented in the future. The observed outcomes of this project differed slightly from anticipated results, the primary difference being the higher than expected stakeholder approval. Through the creation of the project, there was a hope for approval of the created clinical practice guideline by stakeholders, but an anticipated result of rejection. However, collected results from the agreed-to tool showed a high approval of the guideline and acceptance into practice with minor modifications. Logically, next steps for the created clinical practice guideline would be to implement the guideline into practice after minimal modifications to increase patient outcomes as current research suggests. Implementation of any guideline can be time-consuming and a difficult process, but finding the facilitators and barriers to implementing the guideline should be the first step. Along with this, increasing stakeholder involvement may help to develop the guideline further. Implications for practice depend solely on the implementation of the created clinical practice guideline. This guideline can guide practice to use cannabinoids effectively alongside dietitians to increase patient appetites, caloric reuptake, and weight of the patient to effectively increase their overall quality of life. Overall quality of life changes would be based on increased energy levels and higher nutritional status through better intake of food caused by the use of cannabinoids to increase their appetite. There would also be a decrease in patients missing treatments as they maintain healthy weights to continue getting their chemotherapy treatments, decreasing toxicity, and continuing with the dosage they originally started on. Finally, there would be a decrease in patient mortality related to nutritional deficits and wasting symptoms, as the patient is able to maintain a healthier weight with increased appetite and using dietary guidelines. This scholarly project set out to answer the population, intervention, comparison, outcome, and time question of, in adult patients experiencing cachexia from cancer, does the evaluation of a clinical practice guideline, or CPG, using the agree-to tool as compared to current practice provide consensus among stakeholders to support the implementation of the CPG into practice? As cancer cachexia is a disease that devastates cancer patient populations and increases patient mortality, this project was essential to practice. Appetite stimulation was chosen as the focus of the guideline as research shows that with increasing appetite comes increased caloric intake. Increasing appetite and caloric intake will hopefully lead to increased adipose tissue and skeletal muscle, thus increasing patient outcomes. Through the use of the agree-to tool to evaluate the created guideline for the cancer care clinic setting to use cannabinoids in the treatment of cancer cachexia patients, the guideline was found to be accepted by all evaluating stakeholders, to be implemented into practice with little to no modifications needed. With the agree-to tool results, the guideline was shown to be strong in all domains, with the lowest score being a 75% in Domain 5. Most questions that were asked in the evaluation of the domains of the guideline were found to be scored at a 7 out of 7, showing high quality in the created guideline. The collected data showed that the research for the guideline and created guideline both had many strengths and few weaknesses. Looking back, some changes should and could have been made, such as the implementation of an auditing system into the guideline to improve it, or change it as new evidence-based literature becomes available. More time should have been allotted to getting results from the agree-to tool, as data collection from this tool can take several months to be completed properly with adequate feedback and scoring. Also, there should be a dedicated application for communication, as emailing is not the most effective route of communication with providers with busy schedules. Overall, the creation and completion of this scholarly project for my DNP course and the DNP course itself allowed me to increase my understanding of the healthcare system workings, improved my leadership skills, and greatly increased my scholarly knowledge. Are there any questions that are being posed by the audience? Here are the references used in my scholarly project's presentation.